Thanks, Dave. And I guess that's a segue after Axel debunked all of cost-effectiveness analysis. I'll talk mainly about aspirin, which costs for about a year about $10. So maybe that's a good segue. So I was charged to talk about inflammation in colorectal cancer. There are my disclosures. And so I'm going to focus primarily on people who already have the disease, but I'll talk a little bit of data related to the risk of developing disease and how some of these aspirin and COX inhibitors can affect the risk of developing disease as well as polyps. So most people, when they think about aspirin and COX-2 inhibitors, think about its effect on COX-2. COX-2 is an important bridge between the conversion of arachidonic acid to prostaglandins. You can see then you have a variety of downstream pathways that ultimately lead to growth, migration, anti-apoptosis, and angiogenic effects. There are also, as you can see up here on the top, there's effects of other things that can affect this pathway, including some energy balance factors of obesity and vitamin D, and I'll talk a little bit about those, but I'll focus again primarily on aspirin and COX-2 inhibitors. And COX-2 inhibitors can also have non-COX-related pathways. So included in that is there are some effects related to the antiplatelets. So when you have the effects of COX-2 inhibitors can affect thromboxane, which then relates to the release of what's SIP1 here, and that has direct effects from the platelets that can have direct effects on angiogenesis as well as growth. You also have various growth factors that can be affected and directly inflammation. So there are a variety of pathways. It's not actually really clear which pathways are most important related to the development and of tumors as well as progression of tumors, but I'll show you the data looking at some of these factors. So and focusing first on the risk of developing colorectal cancer, there's been a lot of cohort and case control studies where people have followed people over time, looked at who was taking aspirin, most of them for cardiovascular disease, and the risk of developing colorectal cancer, and really consistently most of them show an inverse association. Just as several examples, the Cancer Prevention Study 2, which was a study through the American Cancer Society of over 600,000 men and women, aspirin use at least 16 times per month, a 40% reduction in colorectal cancer mortality over a 6-year period, daily use of an aspirin of at least a full dose for at least 5 years, a reduction of about 32%. The Health Professional Follow-Up Study, which is a cohort study of male health professionals that were followed since 1986, 47,000 males, where every 2 years there's assessment of various exposures as well as different diseases that develop, and those who are regular aspirin users had about a 21% reduction in the development of colorectal cancer, and a similar sister study to the health professional that started before the health professionals. The Nurses' Health study started in 1976, had 82,000 women followed, and again, those who were regular aspirin users had a greater than 20% decreased risk of developing colorectal cancer. These are data from various intervention trials, but not specific to colorectal cancer, but for cardiovascular disease, but following the development of colorectal cancer in those who participated in interventions for cardiovascular disease. And you can see here both the incidence as well as colorectal cancer mortality is significantly decreased in those randomized to aspirin versus placebo in these various trials. And you can see that there's some suggestion of increasing effect with longer duration of therapy. Now, mechanistically, thinking again of the pathway, what's also been studied is the expression of COX-2 in colorectal cancers has been associated with outcome. So those who are COX-2 positive, which are more likely to have distal and P53 positive tumors, less likely to be MS high and SIMP high tumors, have about a 70% increased risk of colorectal cancer mortality compared to those who are COX-2 negative. And thinking about if you're the potential interaction between aspirin use and COX-2 inhibition. These are data from the Nurses' Health Study that looked at tumors that looked at patients who were taking aspirin versus not taking aspirin. Regular users, again, had about a 27% decrease risk of developing colorectal cancer, and that was really associated with a decreased risk of COX-2 positive tumors versus no real association seen with COX-2 negative tumors. And so I'm supposed to talk about the yin and the yang of inflammation, and I assume that would mean the sort of downsides related to trying to influence inflammation by these inhibitors. So the concern, obviously, and really the reason the U.S. U.S. Preventive Task Force and others haven't recommended universal use of aspirin to prevent colorectal cancer relates to some of the inherent risks, bleeding being the primary one that people are concerned about. And so this is a meta-analysis of 35 randomized controlled trial of aspirin, not, most of them for cardiovascular disease as well as other trials for other diseases, looking at the risk of a GI bleed, where you could see the hazard ratio of 1.55 compared to an inert control. To translate that, because hazard ratios and relative risk relate to you have to know what the incidence is to start with. And so if you think about the average risk individuals, this translates to 1 to 2 GI bleeds per 1,000 person years. So if you have people take it for about 40 years, you're thinking about 1 out of 100 people having the development of a GI bleed. Some, but not all, studies show that such toxicities are largely dose-related. The other major bleed of concern is an intracranial bleed, and you can see there the relative risk is similar, about 1.4, but 1 to 2 intracranial bleeds per 10,000 patient years of risk. So there are real risks, and again, kind of weighing what's the risk of developing colorectal cancer and what's the risk reduction compared to the risk of bleeding has led some to not, or many to not universally recommend the use of aspirin to prevent colorectal cancer, but there are probably some subgroups which are still probably need to be better defined of who should be taking to prevent their risk. Now, thinking about patients who've already had a polyp, so a precursor to colorectal cancer, and how some of these inhibitors may affect their risk of subsequent polyps. So there have been studies both in aspirin, and I'm going to focus on studies of a COX-2 specific agent, Colocoxib, and this is from the APC trial, looking at people who had a prior polyp, and they were randomized to either 200 milligrams twice a day or 400 milligrams twice a day of Colocoxib for up to 3 years. This trial, as many other COX-2 trials, what occurred in many other COX-2 trials, closed early because of the discovery of cardiovascular risk, which I'll show you in a second. But what you can see is the patients who were randomized to either 200 twice a day or 300 or 400 twice a day had a reduction in subsequent polyps. The trial was supposed to be a 3-year intervention, and you can see that effect continued beyond 3 years, where you see the 5-year data listed as well. Now, there have been many analyses looking at, again, going back to the Yang part, in terms of the risk of Colocoxib in these patients. And so this is a cumulative endpoint combining 2 trials that were looking at Colocoxib and a polyp recurrence. And you can see here this was using a meta-analysis combining several GI bleeding endpoints. And you can see there's not a significant difference between placebo and Colocoxib in terms of GI bleed. It technically didn't reach non-inferiority because the hazard ratio of 1.22 had to have an upper limit of the 95% confidence interval of 1.26 or something, and it was like 1.5. So it's not non-inferior. There's clearly some increased risk, but you can see here, and again, just looking at, focusing on the scale here, you could see that it's about 1.5% when you get out about 2 years. In terms of cardiovascular risk from the COX-2 inhibitor, which is what led ROFECOXIB, which is Vioxx, to come off the market, and concern regarding the other COX-2 inhibitors, this is an analysis done by Scott Solomon and others that looked at various trials that were using COX-2 inhibitors for prevention of several different conditions, primarily polyp-related, though there was a study in Alzheimer's disease and there was a study in breast cancer. And you can see here there were different dosing, and so I grouped the dosing either 200 twice a day, 400 twice a day, or 400 once a day. And you can see there's a cardiovascular risk is listed above, where the safest dose is actually doing daily dosing of celecoxib based on these analyses, where there really isn't a significant difference when you do daily dosing for cardiovascular disease versus placebo. And then sort of moving on the spectrum, this is looking at polyps in patients who've already had colorectal cancer, so not looking at colorectal cancer recurrence, but recurrent polyps in this patient population that obviously has a higher risk of subsequent polyps. This was a randomized study done by one of the cooperative groups, CLGB, where they were randomized to 325 milligrams daily of aspirin compared to placebo, and you can see a reduced risk of advanced polyps in this population. So now focusing a little bit on patients who've already had colorectal cancer and how these how these agents may affect those patients. So these are data, again, from the Nurses' Health Study, Health Professional Follow-up Study combined, looking at regular users of aspirin, which is defined as 2 tablets per week of aspirin use. And it was looking at both the people who use aspirin prior to their diagnosis as well as looking at people who use aspirin after their diagnosis. So this is focusing on 1,279 patients from those 2 studies who had non-metastatic colorectal cancer at the time of diagnosis, so about 1,200 patients. And there was no association with those in terms of outcomes, both colorectal cancer mortality as well as overall mortality in those patients who are using aspirin prior to their diagnosis. But you can see that those who use aspirin after their diagnosis, and you might say those should be the same people, and there's definitely people who change their behavior over time. And so there are the people who were using aspirin after their diagnosis had about a 29% decreased risk of colorectal cancer specific mortality and about a 20% decrease in overall mortality compared to non-users. Again, most of these patients are using aspirin for other reasons, primarily likely cardiovascular, but those who did develop colorectal cancer seem to suggest an association of a benefit. And when you look at post-diagnosis aspirin and related to dosing, there is some suggestion of a dose effect, where more tablets per week had an improvement both in colorectal cancer as well as overall mortality. And you also see that this is, you could say, well, again, that people who used aspirin after their diagnosis clearly also used it prior to their diagnosis. But if you look at this subgroup analysis, those who were using aspirin prior to their diagnosis didn't actually have an association with outcome, but those who were non-users prior to their diagnosis did have an associated outcome. And again, that goes back to the fact that those who develop colorectal cancers on aspirin have a higher risk of COX-2-related tumors. So this is looking at the COX-2 expression, and so those who are COX-2 positive are the ones who had an improvement in their outcome by having aspirin usage after their diagnosis. And we see that this effect is not associated with either age or gender or stage of disease, site of disease, colon or rectal, when they were diagnosed, nor their level of adiposity, at least measured by BMI. So this is a second analysis that we conducted in our group looking at patients who participated in CLGB 8903. As people probably recall, CLGB 8903 was the study of 5-FU and leucovorin versus 5-FU, leucovorin, and irinotecan, and the weekly IFL regimen didn't show a difference between the two in patients with stage 3 disease. We, in that study, incorporated questionnaires, both given while they were receiving chemotherapy and about 6 months after they completed chemotherapy. And part of the questionnaire was whether patients were using aspirin and the doses of aspirin used. And again, we defined users of aspirin as those who were taking at least 2 tabs per week of aspirin. And you can see here the top panel is looking at recurrence-free, disease-free survival. The middle panels are recurrence-free survival, and the lowest panels are overall survival. And you can see that aspirin users had an improvement compared to non-aspirin users in all those endpoints. Now, going back again, thinking about other pathways and the pathway related to COX-2, you can see that there's also an association with PI3 kinase in these patients where COX-2 expression will ultimately feed back to PI3 kinase, which will feed back to COX-2 to increase prostaglandin. Patients who have a mutation have an activation of that pathway, and there have been several studies trying to look at specifically which patients may or may not benefit from aspirin use, and several studies have focused on the PI3 kinase pathway. So the PI3 kinase is mutated in about 10% of colorectal cancers, and these are data from the Nurses' Health Study and Health Professional Follow-up Study looking at users of aspirin and related to whether their tumor had a PI3 kinase mutation. And you can see here that those who had a PI3 kinase mutated tumor had really a large difference in terms of the effect both on colorectal cancer-specific mortality as well as overall mortality when they were using aspirin versus were non-users, where that effect really is not seen in patients who have a wild-type PI3 kinase. Putting those in numbers, you can see about 82% decrease in colorectal cancer-specific mortality, as well as an 82% decrease in overall mortality, about a 46% decrease in overall mortality in those patients who are using aspirin. Now, these data have been replicated in another cohort. This is from the VICTOR trial. So the VICTOR trial was a study that was ongoing in Europe looking at patients who had high-risk stage 2 and stage 3 disease, had completed standard chemotherapy. They were randomized to either 2 years, 5 years, or placebo of ROFECOXIB. The study was supposed to enroll 7,000 patients. It closed because of the cardiovascular concerns that came up with the COX-2 inhibitors, particularly ROFECOXIB, after only about 2.5 years. So most patients had less than 1 year exposure of ROFECOXIB. It did not show a difference or a significant difference in the effect of ROFECOXIB. The hazard ratio was 0.89. But in the study, there was also patients that were allowed to take a low dose of aspirin. And when you look specifically at those who were taking low-dose aspirin while they were randomized also to ROFECOXIB or placebo, you can see that those who had a PI3 kinase mutated tumor had a significant benefit in terms of association for both recurrence-free and overall survival compared to those who were not on a low dose of aspirin. This effect is actually not seen with the randomization of ROFECOXIB. It's just an observation of the patients who were also taking concurrent aspirin. Now, not all the data for PI3 kinase has been consistent. This is a smaller study looking at patients who are treated both at the Moffitt in Florida as well as Melbourne Hospital, looking at patients specifically who have PI3 kinase mutation and also are taking aspirin, which is about 26% of their 185 colorectal cancer patients that they looked at, and there is no significant difference, as you can see from these two curves, either in colorectal cancer-specific survival or overall survival. So it's still a little bit of an unknown question if this is the right selection marker for patients to be able to determine who should be on these agents. Now, when you look by stage in the study, because that study was mixed stage, it actually, if there is an effect, it looks like it's primarily in patients with stage 4 disease, at least in the Moffitt and Royal Melbourne study. So recently, the cooperative groups led by CLGB, at the time now Alliance, and SWOG completed accrual to this study. It was a study that asked 2 questions. One was a duration of adjuvant therapy, 3 months versus 6 months of FOLFOX, and the second was a randomization to celecoxib versus placebo. The celecoxib is a dose of 400 milligrams daily, which again, from the cardiovascular meta-analysis suggests it was a safer dose than twice daily dosing of celecoxib. This study completed accrual in November of 2015 with expected results in about 2 to 2.5 years. There are other ongoing studies looking at aspirin in this population. So there's a study, the Dutch group is doing a low-dose aspirin versus placebo in stage 2 and stage 3 colon cancer survivals, looking at the primary endpoint of overall survival. There's a study in Asia looking at 200 milligrams versus placebo in a similar population. There's an ongoing study in the US looking at another agent, Solandac, with DFMO. It's a 2-by-2 randomization in colorectal cancer survivors as well as patients who have had a prior polyp, looking for, as a primary endpoint, either high-risk adenomas or secondary primary colorectal cancers. And recently activated in England is the Aspirin study, which is a study looking at several different populations, including breast cancer and colorectal cancer. We'll have about 2,600 patients, again, looking at aspirin. So I think it actually just recently opened. So in terms of thinking about potential other factors related to inflammation, so these, as this original slide showed, also affecting the conversion of arachidonic acid to prostaglandins can also be some other factors, including factors related to energy balance. Listed here is obesity, physical activity is another one, as well as vitamin D. And I'll just show quickly a little bit of data thinking of other factors that may influence inflammation in these patients. So these are data from the Nurses' Health Study, Health Professional Follow-Up Study, looking at their level of physical activity after diagnosis and showing that those who are more active, and the metric used here is what's called metabolic equivalent task unit. So it's a measure of energy expenditure where the way to get 18 met hours is if you walk at a 2 to 3 mile per hour pace for 1 hour, 6 days a week, that's 18 met hours. So it's walking at 2 to 3 miles is 3 met hours. If you jog, it's like 7 met hours. If you run, it's 10 met hours for 1 hour of faster running. So those patients who were more active, indicated by the black dotted line there, you can see have an improvement in terms of colorectal cancer-specific mortality, and this also translated into overall mortality compared to those who were less active. And this has now been replicated in multiple other studies. So this is a meta-analysis that we conducted looking at studies that both came from one study from the cooperative group 8903, as well as other studies, including cohorts from the American Cancer Society, that showed fairly consistently some association between physical activity and outcome in these patients, where you can see about a 25% reduction in colorectal cancer-specific mortality and almost a 30% improvement in overall mortality in these patients. Now, bringing it back to thinking about inflammation, this is a study we conducted in the Nurses' Health Study and Health Professional Follow-Up Study, looking again at the tumors that developed in these patients and looking at COX-2 expression. So those who express COX-2 actually had more of a significant association of a benefit compared to those who were negative for COX-2 for physical activity. So the Q4 through Q1 are quartiles of level of physical activity, where the fourth quartile is the highest, and you can see those who have the highest, which is the sort of orange-yellow line, have an improvement compared to those who were in the lowest quartile physical activity, primarily in those who were COX-2 expressing tumors. These data have led to the development of this trial, which is an ongoing trial through the NCI of Canada, as well as participation in multiple other countries, including in Australia. This is led by Kerry Cornea. It's taking patients who have stage 2 or 3 colorectal cancer, completed standard therapy, and they're being randomized to a supervised physical activity intervention compared to just attention control, and with a primary endpoint of disease-free survival. The goal of this trial is about 980 patients. It's about halfway reached accrual. And focusing on another pathway along that can affect COX-2, this is looking at vitamin D. And so this is a study from Ying in our group that looked at blood samples from patients, from subjects who were involved in the Nurses' Health and Health Professional Follow-Up Study who developed colorectal cancer. Those who had a higher level of serum vitamin D had an improvement in terms of overall mortality. And when she looked at a predictive score of vitamin D, since a lot of those patients in that study didn't have blood samples, but there are ways to look at predictive scores because your vitamin D is primarily influenced by factors like obesity, level of sun exposure, physical activity, as well as oral intake. And you can see here that those who had the highest predicted level of vitamin D had an improvement, so that's the top line in this, both in colorectal cancer specific patient-specific mortality and overall mortality. And she recently presented these data from 8405, the study of FOLFOX or FOLFIRI randomized to cetuximab or bevacizumab in patients who have stage 4 or metastatic disease. There was a blood drawn done at the initiation of the study, and looking at the vitamin D levels, those who had higher vitamin D levels had a significant improvement both in overall survival as well as progression-free survival compared to those who have lower levels. And so looking at sort of a conclusion, aspirin consistently shown to have chemopreventive effects against colorectal cancers. It's still a question who should go on it in terms of preventative role, which is the right patient, how long you should be on it, and the dose is still an ongoing question. Though most studies have shown that increasing exposures, higher doses is probably relatively better. Aspirin and COX-2 associated with reduced risk of recurrence and improved overall survival. There's potential markers to look at whether they're the right to select patients who should be chosen or recommend, or more highly recommended to use these agents, I think is still unknown, and there's ongoing trials. And within all those ongoing trials, there's a host of companion studies looking at these various markers. And again, thinking about inflammation, there are other exposures that also, one of the pathways of which they may have an association with outcome is through inflammation, and the data, I think, for physical activity particularly, and increasingly for vitamin D, certainly suggests that those may be beneficial for colorectal cancer survivors as well. Thank you.